welcome to this episode, where we're diving deep into some of the more complex, congenital, and acquired structural defects and obstructive disorders of the pediatric gastrointestinal tract. We're covering a lot today, from cleft lip and palate to esophageal atresia, abdominal wall defects, hernias, and various intestinal obstructions. It's a comprehensive look at embryology, clinical presentation, surgical management, and long-term care. Chloe, it's quite a spectrum, isn't it?
Absolutely, Liam. These conditions really highlight how intricate embryological development is and how small disruptions can lead to significant clinical challenges. I think starting with cleft lip and palate makes sense. They're among the most common congenital malformations of the head and neck, and they set the stage for understanding the complexity of these disorders.
Right. So cleft lip, or CL, results from a failure of fusion between the maxillary and median nasal processes during embryogenesis, specifically between weeks 7 and 11 of gestation. Meanwhile, cleft palate CP involves failure of fusion of the two palatal shelves, which happens a bit later, between weeks 7 and 12. They can occur separately or together, which we often refer to as CL/P.
And that timing difference is crucial because it explains why CL and CP, although often seen together, are distinct malformations embryologically. The maxillary and nasal processes fuse earlier to form the lip, while the palatal shelves fuse later to form the palate. This also impacts clinical presentation and surgical timing.
Exactly. Epidemiologically, in Canada, CL/P occurs at about 9.4 per 10,000 births, and isolated CP at 7 per 10,000. There's a clear male predominance in CL/P cases. 60 to 80% are male, while isolated CP is more frequent in females. Also, unilateral clefts are 9 times more common than bilateral, with a left side predominance.
That left side predominance is interesting. And there's a higher incidence in certain ethnic groups, including indigenous populations. It's a reminder that genetic and environmental factors interplay here.
Speaking of which, the underlying cause is a genetic defect in cell migration that prevents the maxillary and premaxillary processes from fusing properly between the 3rd and 12th week of embryonic development. But environmental teratogens also play a significant role. Alcohol, cigarette smoke, anticonvulsants like phenytoin, steroids, retinoids, and folic acid deficiency have all been implicated.
Phenytoin is particularly notable, with a tenfold increase in the incidence of CL when used during pregnancy. And Canadian data also suggest maternal obesity and smoking as risk factors. So it's a multifactorial etiology.
Clinically, cleft lip is usually obvious at birth, but cleft palate can be more subtle and requires careful oral examination. CP creates a communication between the oral and nasal cavities, which impairs the infant's ability to generate negative pressure and creates suction during feeding.
That feeding challenge is a big issue. Infants with isolated CL often breastfeed successfully because the breast tissue can conform to the cleft, especially with cheek support, to improve lip seal. But infants with CP or combined CL/P often struggle with conventional feeding methods due to impaired suction.
Right, and that's where specialized feeding techniques come in. Upright positioning helps gravity assist the flow of milk, reducing nasal regurgitation. Breastfeeding is still viable, with the nipple positioned deep in the oral cavity to facilitate tongue action. And special feeders like the Haberman feeder or Mead-Johnson bottle are designed to compensate for the impaired suction.
Feeding obturators are sometimes used to help with feeding by increasing compression surfaces in the oral cavity, but evidence suggests they don't improve feeding efficiency or growth in the first year. So their role is somewhat limited.
Surgical repair of CL typically occurs between 2 and 3 months of age, using techniques like the Fisher or Millard rotational advancement. For CP, repair is usually done before 12 months to optimize speech development, with common procedures including the Vaux-Wardell-Kilner VY pushback and the Furlow double opposing Z-plasty.
And even after repair, about 20 to 30% of children with CP need secondary surgeries to improve velopharyngeal closure for speech. Procedures like palatal lengthening or pharyngeal flaps may be necessary.
Postoperatively, protecting the surgical site is critical. Parents are advised to apply petroleum jelly and use elbow immobilizers to prevent the infant from disturbing the sutures. Pain management is also essential to prevent crying, which could stress the repair.
Feeding resumes gradually, often with syringe or soft cup feeding initially, and some infants can breastfeed immediately after surgery with good lactation support. It's a delicate balance.
Long-term, speech therapy is often required due to velopharyngeal dysfunction, articulation errors, and hearing impairment from recurrent otitis media. Orthodontic and prosthodontic interventions may also be needed.
And we can't overlook the psychosocial impact. Physical appearance and speech quality affect self-esteem and social adjustment, so family support and multidisciplinary care are vital.
Absolutely. Moving on. Esophageal atresia and tracheoesophageal fistula, EA and TEF, are another set of congenital anomalies resulting from failed separation of the esophagus and trachea during the 4th week of gestation.
EA is the most common esophageal malformation, occurring in about 1.7 per 10,000 live births, with over 90% associated with TEF. These often occur as part of syndromic associations like Vactorol, DeGeorge, Down syndrome, Pierre-Robin, Fanconi, and Charge syndromes.
Clinically, excessive salivation and drooling are early signs. The classic triad of TEF includes coughing, choking, and cyanosis during feeding. Apnea, respiratory distress, and abdominal distension may also be present.
Maternal polyhydramnios is seen in about half of cases due to impaired fetal swallowing. Diagnosis involves attempting to pass a radiopaque catheter into the esophagus. Obstruction suggests EA. Chest X-rays help identify the blind pouch and presence of gas in the stomach, indicating TEF.
Prenatal ultrasound can detect polyhydramnios, but isn't definitive for EA-TEF. Initial management focuses on stabilization, keeping the newborn NPO, providing IV fluids, elevating the head to prevent aspiration, and continuous suction of the upper pouch.
Surgical repair involves thoracotomy or thoracoscopic approaches to ligate the fistula and perform esophageal anastomosis. In preterm or unstable infants, staged repair with gastrostomy and delayed anastomosis may be necessary.
Long gap EA, where the esophageal segments are too far apart, may require esophageal replacement using colon or gastric tube interposition or growth induction techniques.
Complications include tracheomalacia in up to 75% of infants, though only 10 to 20% have significant symptoms like barking cough, stridor, wheezing, and apnea. Anastomotic leaks, strictures, dysphagia, and gastroesophageal reflux are also concerns.
Postoperative care emphasizes pain management, airway maintenance, chest tube care, and gradual reintroduction of oral feeding after confirming anastomotic integrity. Monitoring for respiratory complications and feeding difficulties is ongoing.
Parental support is critical throughout. Encouraging visitation, participation in care, and education on suctioning, signs of distress, and feeding techniques help families adjust.
Now, hernias and abdominal wall defects. These are common in pediatrics, but vary widely in severity. Umbilical hernias are frequent and often close spontaneously by age 1 to 2 years, with surgery reserved for persistent or large defects.
Inguinal hernias are more common in boys and can become incarcerated, requiring urgent intervention. Congenital diaphragmatic hernia, or CDH, involves abdominal organs herniating into the thoracic cavity, causing lung hypoplasia and severe respiratory compromise.
Abdominal wall defects include omphalocele and gastroschisis. Omphalocele is a defect of the umbilical ring with herniated abdominal contents covered by a peritoneal sac, often associated with other anomalies like GI, cardiac, and genitourinary defects.
Gastroschisis is herniation of bowel through an abdominal wall defect lateral to the umbilicus without a covering sac. It's less commonly associated with other anomalies, but carries risks of bowel inflammation and necrosis.
Preoperative care for both focuses on protecting exposed viscera with moist saline gauze and plastic wrap, maintaining thermoregulation, fluid and electrolyte balance, gastric decompression, and antibiotics.
Surgical closure follows gradual reduction of contents, sometimes using a celastic silo for staged reduction. Postoperative care includes monitoring for infection, bowel function, and circulation.
Survival rates have improved significantly, over 80% for omphalocele and over 90% for gastroschisis. However, feeding difficulties and gastroesophageal reflux remain common long-term issues.
Turning to gastrointestinal obstructions, these can be congenital or acquired, presenting with colicky abdominal pain, vomiting, distension, constipation, dehydration, and potentially shock or sepsis.
Congenital causes include atresia, imperforate anus, meconium ileus, malrotation, Hirschsprung disease, volvulus, and incarcerated hernia. Acquired causes include intussusception, pyloric stenosis, and tumors.
Hypertrophic pyloric stenosis, or HPS, is characterized by hypertrophy and hyperplasia of the pyloric circular muscle, causing gastric outlet obstruction. It typically presents between 2 and 5 weeks of age with projectile, non-bilious vomiting, dehydration, and metabolic alkalosis.
It's more common in males, especially those of Northern European descent. Diagnosis involves palpation of an olive-shaped mass in the epigastrium and visible gastric peristaltic waves. Ultrasound confirms an elongated, thickened pyloric channel.
Lab findings often show hypochloremic metabolic alkalosis and elevated blood urea nitrogen due to dehydration. Treatment involves preoperative correction of fluid and electrolyte imbalances, followed by surgical pyloromyotomy, often laparoscopic.
Postoperatively, feeding is gradually reintroduced, and vomiting may persist for a day or two due to edema. Monitoring incision sites and hydration status is essential, along with parental reassurance.
Intussusception is the most common intestinal obstruction in infants between 5 months and 3 years. It occurs when one bowel segment telescopes into another, causing vascular compromise and mucosal bleeding.
The classic triad, abdominal pain, palpable mass, and current jelly stools, is present in less than 30% of cases. Presentation includes episodic severe abdominal pain, vomiting, lethargy, and bloody stools.
Diagnosis is confirmed by ultrasound, and rectal exam may reveal blood and mucus. Treatment is usually non-operative reduction with air or hydrostatic enema under imaging guidance, successful in 80 to 95% of cases.
Surgery is reserved for failed reductions or complications. Nursing care involves monitoring for shock and dehydration, preparing families for procedures, and post-procedure monitoring of vital signs, bowel function, and recurrence.
Malrotation and volvulus result from abnormal embryonic rotation of the intestines around the superior mesenteric artery. Volvulus is twisting of the bowel causing ischemia and necrosis.
Clinically, these present with bilious vomiting, abdominal distension, and GI bleeding. Diagnosis is by upper GI series, and surgical emergency involves resection of necrotic bowel and anastomosis.
Postoperative risks include short bowel syndrome. Nursing care focuses on stabilization, NG decompression, fluid management, and close postoperative monitoring.
Finally, anorectal malformations occur in about 1 in 5,000 births, more commonly in males. They range from imperforate anus to complex cloacal malformations.
Embryologically, these result from failure of cloacal division and urorectal septum formation. Classification varies by gender and anatomical defect, including perineal fistula, rectourethral fistula, vestibular fistula, imperforate anus, rectal atresia or stenosis, and cloaca.
Diagnosis involves noting absence of anal opening, abnormal meconium passage, and imaging to assess associated anomalies. Treatment ranges from anoplasty for simple fistulas to colostomy and posterior sagittal anorectoplasty, or PSARP, for complex defects.
PSARP allows precise muscle dissection to optimize continence. Laparoscopic primary repair is increasingly used to minimize surgical risks.
Postoperative care includes anal dilations to prevent strictures, skin care, pain management, and nutritional support. Long-term bowel management programs are often necessary.
Prognosis depends on defect severity, muscle quality, and associated anomalies. Nursing roles include early detection, parental education, and support for bowel management.
So, to wrap up, these structural and obstructive GI disorders in pediatrics are complex and deeply rooted in embryological development. Their management requires a multidisciplinary approach addressing surgical repair, feeding challenges, speech and developmental support, and psychosocial care.
Exactly. Early diagnosis, stabilization, and comprehensive nursing care are critical across all these conditions. And supporting families through education and emotional guidance is just as important as the medical interventions.
Thanks for exploring these intricate topics with me today. It's a reminder of how much expertise and collaboration go into caring for these vulnerable children.
Absolutely. Thanks for the great discussion. Looking forward to our next deep dive.